morning, everyone. This is Dee Logan from iSPARC. We're so happy you could join us today for our webinar, Suicide Risk Detection and Management in Clinical Settings, Implementation Challenges and Lesson Learned by Dr. Ed Boudreaux. Before I turn it over to Dr. Boudreaux, I'm just going to go over a few housekeeping items. Please note that this broadcast is being recorded and will be available soon for viewing on iSPARC's website. If you are calling in over the phone, please remember to use your unique audio PIN. Please move any electronic handheld devices away from your computer and speakers. We do recommend that you close any and all file sharing applications and streaming music or video. And if you're experiencing any audio problems, please check your settings in the Go to Webinar Audio tab. If you do experience any technical difficulties, you can email me at deirdre.logan@umassmed.edu or use the Questions tab in the Go to Webinar dashboard. And we will be having a live Q&A session after the presentation. If you have questions for the Q&A session, please type them into the Questions tab as you think of them. And we'll start then. And now I'm going to turn it over to Dr. Boudreaux. Thank you very much.
Great. Thank you, Dee. I'm really happy to be here this morning. I'm a clinical psychologist by training, so this issue of suicide risk and suicide prevention is really dear to my heart. It's something that I've been working on in a clinical capacity since I got my graduate degree. And in the past 10 years, I've really focused my research career on this particular issue. So I'm hoping that what we can do today is I can share with you my experiences and get you kind of up to date on what the latest models in suicide risk detection and management in clinical settings are, and talk specifically about some of the stuff that we're doing here at UMass. So our learning objectives are that by the end of the seminar today, you should be able to identify tools for detecting suicide risk and prioritizing evaluations in acute care settings. We're focusing on acute care settings because that's primarily the work that I've done, but much of what we talk about today actually has translation potential for outpatient settings as well. So the second objective is to give examples of best practices to intervene on suicide risk in acute care patients and to describe implementation challenges and solutions that we have experienced. So the outline for today's presentation is I'm going to start with a basic background on the current state of suicide epidemiology and suicide prevention in the United States. We're going to then talk about best practices in suicide prevention. Particularly, we're going to focus on the zero suicide model. And we'll talk about implementation across our large healthcare system, which is the UMass Health System. So basic facts. You probably know this already because as you can see from the photo montage here that suicide has really captured the public attention primarily because of some pretty high profile suicides that have occurred over the past few years. It's the 10th leading cause of death in the United States, and it's the second leading cause of death in teens and young adults, which is particularly tragic. You can see that in 2017, there were a record number of 47,000 deaths by suicide in America. And that is only the tip of the iceberg because, as you guys likely recognize, that the death by suicide is although it's increasing, is relatively rare. What's much more common are suicide attempts. There's been an increase in suicide attempts along with the increase in suicide deaths. There was 1.4 million suicide attempts in 2017. So this is a staggering problem. It's one of the main reasons why the overall life expectancy in the United States has actually decreased. It's suicide and opiate deaths have really dragged down our trajectories. So it's a particularly important public health problem. You can see that from here, the suicide rates are increasing not just in one area, but really they're increasing across almost every single state in the nation, with some rates being very dramatically increased. You can see the kind of plaid blue states here where they have an increase from 1999 to 2016 of between 38 and 58%. This is an important slide. I know it's busy, but I'll kind of walk you through it. So most people who die by suicide have had some kind of healthcare visit in the 12 months before their death. So this is one of the latest and most detailed graphs that show exactly what that looks like. So 80% have some kind of healthcare visit before their 12 months before their death, and 50% have some kind of healthcare visit in the 4 weeks before their death. So what this really tells us is that the healthcare setting is particularly important and a rich place to be able to identify patients who are at risk for suicide, and potentially to intervene with them and help to prevent them from acting. It's important too that most of these healthcare visits are for non-behavioral health visits. So we typically think of suicide in the psychiatric patient population, but actually the visits that people are making, some of these may be psychiatric patients, but the visits that they're making to healthcare are for non-psychiatric reasons. And that's an important fact to consider too, because when you think about screening and detection, we typically think about people who are presenting with psychiatric problems. But that's not really necessarily the reason why they are presenting. They're presenting for non-psych problems. And this is also shown in this graph here. So we've helped to pioneer some of this research where we will go out and we will screen for suicide risk in a consecutive fashion among medical patients in emergency departments. And we find that when we do that these are medical patients, incidentally. So this graph is the proportion of medical patients in emergency departments who say yes, they've thought about killing themselves. That's the active suicidal ideation. So it ranges from 2.3% to a high of 8.4%. And then if you look at broader suicide risk, any active ideation and or a lifetime suicide attempt, you see it skyrockets. And these are medical patients. So it's particularly important for us to consider when we're talking about screening, who is the target population? Are we only screening psychiatric patients or people presenting with psychiatric problems, or are we screening everyone? So let's talk a little bit about what suicide risk on a continuum looks like. So you can see here, we've got it kind of arranged from all the way to the left where you've got passive death wish. Some people call this a passive suicidal ideation, all the way to the right where there's death by suicide. Let's take a little bit more of a detailed approach here. So what is passive death wish? This might be represented by someone saying that they wish they were dead or could fall asleep and not wake up. 1 in 8 ED patients actually endorse this item. Active suicidal ideation is actually thoughts of killing myself. So a person might say, I'm thinking about killing myself. 1 in 16 ED patients, ED is emergency department patients, endorse this item. Ideation with method. So now you're moving more towards specificity. So a patient who has active suicidal ideation with method might say, yes, I think I would hang myself if asked if they had thought about a method. Ideation with detailed plan. So now we're getting a little bit more specific here. The person might say, yeah, I would hang myself in the garage with a rope while my wife's at work so she can't find me. And then ideation or intent, this person might act. So you can actually get all the way up to a detailed plan, but not have intent to actually act on the plan. So there's a transition here typically between a person who's been planning or thinking about it and a person who actually has intent. And we typically look at that intent as a very important transition step. Once a person says they intend to kill themselves, then we really begin to worry about the next step, which is the transition from ideation to behavior. And you can see here the first behavior component is preparatory behavior. It might also include interrupted or aborted suicide attempts. So what this might look like is a patient actually buys the rope with which to hang themselves. And then, of course, there's the suicide attempt. The patient puts the rope around the neck and attempts to hang themselves. And then there's the final stage here where we actually have the patient's hanging is fatal. So you can see there's this continuum from basic passive ideation all the way to death by suicide. It's important to think of it as in this continuum because it has implications for what we can do at each one of these stages. So what I've tried to do, this is the first time I present this slide, so If you have any feedback, I'd appreciate it. But what I've tried to do is take some of the more recent interventions that have been developed and map them out into where I think they're most likely to impact this suicide continuum. So all the way to the left, you see therapies to decrease psychiatric symptoms. So these are our traditional therapies. They're, cognitive behavioral therapy or interpersonal therapy or other therapies that are targeting psychiatric symptoms like depression and anxiety or alcohol dependence. Of course, there are medications too that can address these. This might actually be better positioned further to the left. So you can imagine that a person who is depressed might transition to passive death wishes, and if you treat their depression, they may not even get there. So just because we started with the suicide continuum, I put the therapies to decrease psychiatric symptoms all the way to the left. But if you think about how that might work, it's most likely going to affect people. If we create a happier, more positive outlook, less hopelessness, then people are less likely to either develop passive ideation or to transition between passive ideation to actually having active suicidal ideation. Below that, there are also interventions to reduce drivers of suicide. So I use the term thwarted belongingness here. I know it might seem like a strange term, but it's part of a theory of suicide called the interpersonal theory of suicide that points out that a big driver of suicide is this sense that the person doesn't belong, social isolation, etc. And I call it out because later you'll find that some of the interventions that are being used and studied now are pretty simple interventions called caring contacts. And one might imagine that those caring contact interventions, staying in touch and letting a person know that we care about them and we're thinking about them, might actually reduce thwarted belongingness and reduce their thoughts of suicide. If you continue along the continuum here, you see interventions to improve the management of suicidal thoughts and to reduce the transition to action. This is really, really important because historically our approach to reduce suicide has been all the way to the left, has been to promote therapies to decrease psychiatric symptoms. But what we know is that even when we do those therapies, it's not sufficient to actually reduce suicide. In fact, many investigations into what we do with patients with our traditional therapies show that we actually don't discuss or address the suicide risk specifically. And that's a big failure on our parts when we're doing this. And these new interventions that are really focused on improving the management of suicidal thoughts and to reduce action in the crisis moment are very important. Safety planning intervention is an example, and we'll talk a lot more about that later. As you move along the continuum, you can see that there are two kind of buckets that I have here. The top one is lethal means restriction. So if you think about death by suicide or a suicide attempt, it's not only that that person has to have the ideation or the drive to act, but they also have to have accessibility to lethal means. And there are social ways to reduce lethal means restriction. So you guys are probably familiar with gun control laws and restricting access to guns. And there are clear patterns when you look at epidemiology across the world that those places that have less access to guns are less likely to have, are usually going to have lower suicide rates and of course less suicide by firearm specifically. There are also individual ways that you can help to reduce access to lethal means, and that includes counseling with the patient and the family. We'll talk more about that later as well. At the bottom of the continuum, you see inpatient hospitalization and care transitions. The inpatient hospitalization is primarily used to prevent a person from attempting or acting while they're stabilizing. So that's why I put it here. My experience is so far in many, not all, but many inpatient psychiatric facilities currently, you're going to get hospitalized because you have suicide risk. They're going to try to stabilize you on medication and they're going to push you out. They're not going to really do a whole lot about exploring your drivers of suicide, which is also a real miss and a change that we're trying to promote. So this is kind of my best, and care transition. So when people leave from one level of care to another, so from an emergency department to outpatient or from an inpatient to outpatient, we know that that's the most vulnerable time for people acting and that there's a spike in suicides, which is paradoxical, that the person leaves the acute care setting and then there's a spike in suicides. No one's really well described it, but typically the rule of thumb is within 6 weeks of the acute care visit, the risk for suicide in patients who have suicide risk, the risk for actually death by suicide increases. And so what we know is that if we can help with transitioning from the acute care setting to an outpatient care setting, that can help to increase the engagement in behavioral health outpatient care and reduce suicide. So that's a really fast overview of the current state of suicide epidemiology and suicide prevention. And now what we're going to do is we're going to dive in a little deeper into best practices in suicide prevention in acute care settings. The zero suicide model has really captured the national attention, so I'm going to describe this to you and focus on it. There are other models and other theories that are very relevant, but this particular model has really gained a lot of traction, and I feel like it's important to review. It's a priority of the National Action Alliance for Suicide Prevention, and it's a goal for the National Strategy for Suicide Prevention. These are the two leading organizations in the country on suicide prevention that help to set the national agenda, and they have adopted the zero suicide model. That's why I think it's so important to understand it. They point out that there are 7 main performance categories or performance elements of the zero suicide model, and we're going to start with leading. So the system, and these are really targeting healthcare systems. So they're not targeting individual clinicians. They're talking about how a system like UMass or another healthcare system can actually help to better manage and reduce suicide risk. So they emphasize that the leadership of the system or the department or wherever you're implementing this is extremely important, and it really requires not only just a verbal commitment to the program, but it really requires resources to be committed to improving suicide-related care. And they really emphasize culture change, so that this is not just another protocol or a program that people look at as just needing to be shoved through and implemented, but actually it requires a culture change, which of course, as you all know, is incredibly difficult to achieve. Train. So they really focus on training competent, confident, caring workforce. So they really want to focus on how do you train your existing workforce from the registrar all the way through the medical teams, the behavioral health providers, the psychiatrists, the nurses, really looking at every role and figuring out what is this person's role in identifying and preventing suicide, and making sure that each person is trained up to their appropriate role. So most systems that embrace zero suicide will include trainings for people who are answering telephones or who are staffing the front desk. Identify. So obviously you need to identify the patient with suicide risk. So if you don't, you can't really act on it. So we'll talk more about what that really looks like in a little while. Once you identify them, you want to engage that individual. You really have to develop a rapport, develop a relationship, and engage that individual at suicide risk, including creating a suicide mitigation plan for that person. Treat. You have to use evidence-based treatments, which we'll talk about later. Transition. Like I mentioned before, care transitions are incredibly important. So really, systems should pay very close attention to preventing patients from falling through the gaps across their different healthcare settings, and use a process improvement. The last stage is extremely important. Develop policies and procedures through continuous quality improvement in order to be able to focus on the process, develop plan, do, study, act cycles. Are basically what those are just implementing your protocols or your plans or your policies and making sure you have a mechanism in place for studying it. You know, are you achieving what you plan to achieve? And if not, what are their barriers? Identifying solutions for those barriers, implementing them, and then studying it again in an iterative cycle until you've reached your goals. I like this quote from Thomas Praselic, who is the CEO of Cedars-Sinai Medical Center that has embraced the zero suicide model. The zero of the zero suicide model has been very controversial because some people feel like it sets an unrealistic expectation. Can you really design a system that has 0 suicides. So he's kind of spoken to this issue and said that he feels like it's really important to design for 0, even when it may not be theoretically possible. It's about purposefully aiming for a higher level of performance. And it is considered a 0 event by the Joint Commission and other accreditation agencies. And what that means is every single time a suicide attempt or suicide happens in a healthcare setting, it has to be documented and reported to the Department of Public Health. And this has happened several times at UMass. And so I can tell you that this idea of 0 is certainly embraced within the healthcare and acute care settings. It should never happen. And anytime it happens, we need to identify and learn from the occurrence. This is also a great slide. You guys may be familiar with James Reason's Swiss cheese model of accidents. It also applies here with suicide risk. So you've got this suicidal person, who presents to care in a healthcare system. Are they being asked the appropriate questions to identify if they're suicide risk? If they don't, then they slip through the crack. Are we acting to appropriately put into place procedures that are going to keep that person safe? If we aren't, even if we've identified that they have suicide risk, if we're not doing the right things, then they can slip through the cracks. Are we reducing access to lethal means? In the acute care setting, for example, that might mean things like making sure that the room that they're in is ligature resistant. Are we actually treating the suicidality? So are we actually focusing on the drivers of the person's suicide risk? Are we paying enough attention to really what's causing the person to feel suicidal? And if we're not, then we can slip through the cracks. And then finally, even if you can do all of these things successfully, and you might imagine we could do that, let's say on an inpatient unit, but if the person isn't really engaged and there's no support whenever they leave the setting, then we still are failing, and this person can slip through the cracks and end up attempting to kill themselves or have death by suicide. This is an important graph for the 0 suicide model because it's where the whole process started. Henry Ford Health System launched what they called the perfect depression care, and this evolved into the 0 suicide model. And it was a grant that was funded by the Robert Johnson Foundation. And when the team there at Henry Ford was trying to figure out what metrics to track, they identified the typical metrics of depression. And you guys probably know how that's measured. It's usually measured with the PHQ-9 or some other scale. But they were challenged to come up with a more objective measure that wasn't entirely subjective that they could track. And they came up with suicide as their objective measure. And you can see here they launched their perfect depression care in around 2000. So 1999, 2000, they launched it. And this is their suicide rates for their HMO members. You can see they actually did achieve 0 suicides in 2009. So that was the only year they had 0 suicides. But you can also see here that there appears to at least be a dramatic decrease in the total suicides or the suicide rate in this HMO patient population. And this is what really it caused the rest of the country to kind of pay attention and to start thinking about whether what Henry Ford was doing was applicable to other areas. But this was a fairly uncontrolled study because there was no comparison group, there wasn't a control group, it wasn't randomized. So it was basically just like a time series analysis, but it was interesting enough to warrant further attention. And NIMH has funded a bunch of 0 suicide studies that increase the rigor of the methodology to try to better study this and understand really where the effectiveness comes from. And we have one of those grants, and so we'll talk about that specifically at UMass later. So what does identify mean? So I'm not going to focus on all 7 performance elements of the 0 suicide model. We're just going to focus on a handful of them that I think are most relevant to the discussion today. So identify, what we promote is universal screening to detect and stratify. And the reason why we promote universal screening, meaning we're going to screen people regardless of their reason for presentation, is because of the data I showed to you earlier. Number one, people come in for non-behavioral health problems, and then they go on to die by suicide. And if you ask people the questions, they're often quite forthcoming, and they'll tell you when we have very high proportions of patients in EDs and inpatient medical units who will admit to suicide ideation if you ask them. So this typically happens in two stages. The primary screening is usually something very quick that's designed to detect if non-negligible risk exists. So if they are positive on the primary screener, you go on to the secondary screener. If they're negative, then you don't do anything else. And so it has to be fast, it has to be sensitive, and it has to be focused on simply determining yes or no. It's a binary kind of decision. But then the secondary screening aims to stratify that clinical risk into more gradients. And so there's a lot of controversy around using stratification and suicide risk. And so I won't go into all the controversies, just recognize that most of this screening is done for categorization early during the healthcare encounter, which is necessary because it puts people on pathways. The idea that you can have a much more gradient and spectrum assessment of suicide risk is important. And I really advocate that as a psychologist. I realize you just can't bucket people into groups. But early in the medical treatment processes and the healthcare treatment processes, it is important to bucket people into groups because you don't have the capacity to do a really deep dive and really understand this person's suicide risk early in the visit. That doesn't happen until later. So categorization and stratification is essential in healthcare, particularly acute care healthcare settings, to be able to guide early decision making. The Patient Safety Screener 3 is the screener that my team and I have developed. It's got 3 items. I'm not going to go into detail here, but basically it assesses depression, active suicidal ideation, and lifetime attempt. And if the person attempted suicide in their lifetime, we find out when the most recent suicide attempt was. So we've validated this instrument. The administration of the tool in the general adult and ED medical patients and psychiatric, for both medical and psychiatric presentations. We administered the tool in this validation study. We compared it to the reference standard, which is the Beck scale for suicide ideation. You might ask, why don't you just use the Beck scale in the ED or acute care? That's because it takes way too long. It's a very complicated screener. So what we're looking for is something that we could administer that was short, 3 items, and which had a real high correspondence to this reference standard, the Beck. And what we found is that our instrument was very strongly related with the Beck, and that we could get a high level of agreement between a person who is considered positive on our 3-item screener and a person who's considered positive on the Beck. So this was one of our first validation studies. We've since done a bunch more, but I'm not going to review those in depth today. Even more importantly than the validity study, we had a very large study, 8 sites across the country, the emergency department safety assessment and follow-up evaluation, the ED SAFE, where we implemented the Patient Safety Screener 3 into routine clinical care. So this was used for all patients who are 18 years and older. You see this time series graph here. All the way to the left is our treatment as usual phase, and we have all 8 sites plotted there. And you can see that on average, only 26% of the emergency department patients in our 8 sites were being screened during the control phase, the treatment as usual. In the middle phase is where we implemented universal screening. So between those 2 phases, treatment as usual and universal screening, we actually implemented trained staff, and then we started to track screening. And you can see that there was a significant uptake in the proportion of patients screened. From 26% to 73% of all the adults were screened. And we continued this last phase all the way to the right. We continued to enhance the screening and added some additional interventions that were provided at the ED visit and after the ED visit. You can see our continued process improvement, that CQI model, pushed the screen rates to 85%. So these are, by the end of the study, we had 85% of all ED patients who were being screened. That's about as high as you can get, because you can imagine in the ED, there's a significant proportion of patients who simply aren't screenable because they're suffering some sort of medical or cognitive emergency, and they're just not able to be screened. So we demonstrated in this study that universal screening in emergency departments is feasible because these sites ranged from small community sites to large tertiary care sites. And as you can see in every single one of them, by the end of the study, got to around that 80 to 85% level, with some of them screening 95% of their ED patients. So what happens when you do this? Well, you start to improve your detection, which is, of course, why you screen. So at the baseline, all the way to the left, you see that about 2.9% of all of our patients who we collected data on had screened positive for some suicide risk. Once we started to improve screening, that increased to around 5.2%, and then the final detection rate after our complete intervention was 5.7%. So we nearly doubled the number of patients who were detected by routine clinical staff who had some sort of suicide risk. So in other words, what I've just shown you is that you can feasibly implement universal screening in acute care, and when you do, you improve your detection rate, which is, of course, the goal. I just wanted to mention a couple of other screening tools that are common that you might run across in your practice. The Columbia Suicide Severity Rating Scale, which is actually a very long scale, but there's a triage version, and many outpatient practices will use this either alone or with the PHQ-9 in order to screen for suicide risk. And for children, there's the Ask Suicide Screening Questionnaire. This is the leading questionnaire for children ages 10 to 24. I know that's a kind of a transition age adults as well, but so it is very similar to the Patient Safety Screener 3 that I just presented, but it has a few additional items, and you might see this as well if you're working in pediatric settings. So that was a brief overview of identifying, screening patients. Now we're going to talk a little bit more about engaging the patient, because an important component, which you could consider intervention, and it's classified in the zero suicide model under engage, but safety planning intervention can also be considered a treat, fall under that too. It falls into both categories. But the Stanley Brown safety planning intervention has grown to become pretty widely accepted across the country, and is the intervention that is used, the safety planning intervention that's used in the VA. It's a VA best practice, and it's been implemented throughout the VA. There's 6 steps to their safety planning. The first is helping to improve the patient's ability to recognize their warning signs, so you can do early intervention. Next, they employ internal coping strategies. So we're trying to walk a patient through a systematic way to cope with these thoughts and with these warning signs whenever they occur, focusing initially on internal coping strategies, and then expanding out, if that doesn't work, to socializing with others and distracting oneself by going to places that could be distracting, get their mind off of it. So you see a lot of this, we're trying to help them cope and trying to help them get distracted. The reason is because most patients, there's been some really good research on this, most patients, they'll experience a burst of suicidal ideation, but it'll go away eventually. The best studies have shown that 15 or 20 minutes, most people who have a spike in suicidal ideation, it will go away, or at least it'll lessen intensity and get them out of the zone where they're at risk for acting. So a lot of the safety planning strategies are really trying to get people to kind of snap out of it by applying their own coping strategies or getting out of the house and talking with other people. If that doesn't work, then the next step is actually contacting family members who can help the person in a crisis, friends, and then if that doesn't work, or if there's no family or friends that they can contact, then they're really encouraged to contact mental health professionals or agencies. And then if none of that works, of course, they go to the emergency department. And then the final step, which you can think of as a final step or the first step, is to reduce the potential for using lethal means immediately once the person returns home. Now, this is often done directly with the patient, but I think the best practice, frankly, from my experience, is really to do this with a significant other if you can, to ensure that the access to the lethal means is actually reduced, and not just a commitment from the patient, but that there's some confirmation that the access has been reduced. So what happens when you implement the safety planning intervention? So a recent JAMA study published these results. You see a significant reduction in suicide behavior reports. These are typically suicide attempts or other suicide preparatory behaviors. So when you look at the control condition versus the safe vet condition, which received the safety plan intervention, there's a significant reduction in the suicide behavior report, which is pretty amazing if you think about it, because this is a relatively short intervention. This intervention, a good safety plan probably does take around 30 or 40 minutes to develop. That may sound like some people that sounds like a really long time, like when I'm working with emergency department clinicians, and other people who are working in outpatient or inpatient don't necessarily think that's a terribly long time. But 30 to 40 minutes to develop a good safety plan, but you reduce significantly the patient's suicidal behavior after they get discharged. One way it might do this is it improves the patient's ability to cope with suicide-related thoughts. It's not going to change a lot about what the patient's situation is, and this shows you don't really have to. So the patient may still have depression symptoms. They may still have, environmental or social constraints that cause them to be depressed. But what you're doing here is helping them to cope with the suicidal thoughts so they don't act. This shows that the improvement in suicide-related coping between the two groups over time. So a part that I mentioned earlier is counseling on access to lethal means, and I want to focus on it. It's a subcomponent of the safety plan and intervention, but it's often viewed as a separate effort. So there are plenty of people, suicide researchers who really focus on this part and feel like it deserves its own attention. So this is really, borne out by those who die by suicide are more likely to live in homes with guns. And so the access to lethal means is really focused on gun access primarily, although it can be focused to other lethal means like medications as well. There's a higher risk of suicide in states with a higher firearm prevalence, and removing access to those lethal means can prevent a lethal suicide attempt or prevent the suicide attempt entirely. There's a pretty widely accepted training called counseling to access to lethal means, and it can be done online. So I love this training because it's actually very relevant. It's quick. It's easy to access. You really probably need additional training or at least practice with it if you're going to do it in practice. But to get the basics, this CALM training is a really good training. Let's talk about treating and transitioning patients. So we know from a recently published study that we have some very cost-effective ways of preventing suicide. So you may hear otherwise, because for a long time, people have focused on the fact that, we're not doing a very good job at preventing suicide. Look, the rates are increasing, and we don't really have any good interventions. But that's a bit of a dated interpretation. And I like this article published last year because they used existing published studies on 3 different interventions. One is very simple, caring contact postcards. So these are when a postcard is sent out to a patient who has some suicide risk, and it's usually a pretty simple postcard that basically says, we're thinking about you, and if you're having any trouble, then call us up, or sometimes it'll have a lifeline number on it. And it's been shown, even that very simple intervention to meaningfully reduce suicide attempts and death by suicide as compared to control conditions that don't receive those caring contact postcards. And you can expand that and think about telephone outreach as also a caring contact. So there are interventions like the ones that we've done here that have someone, usually a clinician, but it doesn't have to be it doesn't have to be a clinician, but someone checking up on the patient, finding out how they're doing, making sure that they're following up with their behavioral health care. So when you look at all of these, you find that they are cost effective at reducing suicide. And this plot is kind of obviously it's complicated, but basically what it shows is even the least of the intensity outcome interventions, the caring contacts, was cost effective at reducing suicide. This is the results from our clinical trial that was also part of ED Safe. And what we saw is similar. We had a telephone contact with patients after the ED visit. And what we found is those patients who received the telephone calls had a reduced suicide risk rate over the 12 months after their emergency department visit when we compared to screening alone or to treatment as usual. So it did show that the screening alone isn't effective. You really need an intervention attached to the screening in order to reduce suicide risk. All right. I'm looking at the time, and we only have about 15 minutes left. So I apologize for breezing through these slides. What I'm going to do is I'm going to describe very quickly to you what we're doing here at UMass, the system of safety, and then I'm going to skip to the lessons learned just so that we can kind of review some of the implementation problems that we've had. In a nutshell, what we did is we have taken the zero suicide model and we have propagated it across the entire UMass Memorial Healthcare System, which is 5 hospitals in the Worcester region. We're targeting the EDs in those hospitals as well as inpatient medical and surgical units, both behavioral health and med-surg, and we're extending it to primary care and specialty outpatient settings as well. So this is a true system-wide effort. You can imagine, the magnitude of this project is huge. So we're about in the middle of it, and we're really engaging providers from nurses, doctors, patient care associates, mental health clinicians, you name it. They're a part of our team. Every team, probably, if you count everyone on the team, there's probably about 300 people on the team. We use a lean hub and spoke model where we've got a centralized hub that works with spokes at all of these different units. You don't have to understand the kind of the details here, but you can kind of see how it works with the hub in the middle and the spokes attached to the hub. And this is just a very quick overview. Remember, I was talking about those performance elements. These are the things that we are implementing in our system currently. I'm not going to go through each one of these. The slides will be available for you if you would like them, but they point out how we're addressing each one of those performance elements in the zero suicide model. I'm not going to go through this in detail either, but if any one of you is interested in knowing exactly what we've done in terms of our workflow and protocol, this is it right here. This is in a nutshell what happens when the person comes in to an ED or inpatient facility at UMass. We do the primary screening, secondary screening. That's used to stratify patients. We implement strata-specific suicide precautions. All of this is reviewed and approved by the physician. They get a behavioral health evaluation, and we're really trying to promote safety planning where the resources are available. And then when they leave, they get referral resources to outpatient care. And eventually in the future, we're hoping to make sure that they get at least one phone call follow-up after discharge to help promote care transitions. All right, let's see. I'm gonna breeze through this because this just goes into more depth with what I was talking about. And here's our lessons learned. So it's really important to find the right task for the right role. So the nurses do well with screening, but to expect a nurse to do safety planning, for example, is just not a good fit. And so we worked hard to try to find and match the right actions with the role or professional role that the person has. Screening was difficult, but it was a lot less difficult than implementing interventions and transitions, which I think you probably recognize is much harder. But screening is relatively easy. We have a very specific ways of doing that, but the interventions and the transition of care, like calling patients after the ED visit, are very tricky and a lot more difficult to get down well. Carrot or the stick. So we got a lot of action here. I mean, we've really got amazing transformation of our system, but that didn't really happen until Marlborough Hospital failed their Joint Commission visit. So the Joint Commission regulates or accredits hospitals, and in June of last year, they failed their visit because of their suicide risk protocols. So prior to that, we were using the carrot approach and trying to implement best practices within the system by working directly with small teams and by helping to educate them and help them find what best practices would suit their systems best. And we're trying to get them to make the changes so that if the Joint Commission showed up, they would pass. Well, that was going very slowly. And then Marlborough happened, and then everything happened very quickly. So I don't think we would be where we are now with a very effective transformation unless we had that stick. Maybe the carrot would have eventually done it, but the stick really helped to catalyze everything. So it's unfortunate, and you can't really cause that to happen. It was just a kind of an accidental thing. So we had a stepped wedge design, which basically means that our approach was going to be staggered so that we had certain groups of units starting our efforts at a given time, and those time periods would be staggered over the course of a period of the 4 years of the grant. This is important to be able to test effects in research. But what happened with the Joint Commission visit is that we suddenly had to transform the entire system at once, which really wreaks havoc on your stepped wedge design, because units that were supposed to not receive an intervention from our team, all of a sudden received interventions that were implemented across the system. So these are sometimes called sentinel or historical effects, and their stepped wedge designs are often very vulnerable to those. So the barriers we noticed did vary by setting. So you can't treat the ED the same way you treat med-surg inpatient units, and you can't treat those the same way you treat psychiatric units. You do have to have some tailoring and customization. And finally, the fidelity to the protocols requires a lot of training, requires ongoing monitoring and buy-in from leadership and frontline support. So there's a big difference between adoption and true implementation. So people will tell you that they're screening. You look on the charts and you'll find that they're screening. But what we did is we went and interviewed patients who had screenings documented on their charts. And we said, were you asked these questions? And a very large proportion of those patients said, no, we weren't. And it's not really accountable to just memory. It's just we've done depth interviews with clinicians, and we find that they often just document it based off of what they call clinical intuition. They don't ask the questions; they just don't think the person's suicidal. So you really have to pay attention to that, because even your documentation can really belie what's really happening. So finally, these are some high-yield resources. I'm not going to go into those in detail, and that was the suicide blitz. So I think, Dee, I'm ready to have a discussion.
Thank you, Dr. Boudreaux. That was very informative, even though you had to go through a little quickly. Thank you very much. Just for everyone, in case you didn't hear, the webinar is being recorded. The recording and the slides will be made available on iSPARC's website. And if you do have questions, please type them in, and we will ask them to send them to Dr. Boudreaux. So I have one question here that I'm not sure if it's something 100% you can answer, but it's kind of interesting. How do you assess suicidal risk versus risk for self-injurious behaviors?
Yeah, well, it's important, and that's a controversial, that's a controversial area, because I think everyone recognizes that they're not really the same thing. And some of the research that was done on this issue has shown that they are separate, that just because you have non-suicidal self-injury doesn't mean that you're at risk for suicide. But then there's been some conflicting literature on this, that actually it is an indicator for suicide risk. So I guess the best way I can describe my clinical approach is, first off, it's important to know that those phenomenon exist, that they are separate, and assessment is usually going to focus around the reasons and the intent behind the cutting or the self-injurious behavior. If you look at the overlap, there are many patients who have non-suicidal self-injury who also have suicide attempts. So it is important to try to separate those two things. The approach that I would take is, anyone who has any kind of non-suicidal self-injury, I would talk with them and approach the situation as though that was a risk factor, and I would establish a safety plan with the individual at minimum, in addition to whatever other therapy I'm using to try to help address the drivers of the non-suicidal self-injury. As everyone probably knows, NSSI and suicide attempts are common in people with borderline personality disorder. So, for example, I would I would use dialectical behavioral therapy with that kind of person to target both. And DBT has actually embraced this safety planning as well. So you could use a safety plan with this person. And sometimes people are reluctant to do that with someone who has non-suicidal self-injury because they say, well, this is not a suicide attempt. And what I would say is that often I can engage the client and say, look, I know this is not suicidal. I know that you're telling me that you're not trying to kill yourself by cutting or burning. But what I am worried about is that there may be a time where your thoughts or you're in a crisis and you're escalating, and it might be something that would enter your mind, and we have to prepare for that eventuality. So what I'd like to do is create this safety plan to make sure that we've thought through what you would do if you had these signs, and if you had these warning signs, if this came up. So you can usually get over the hump by a negotiation with the client. You can also change it a little bit too, because the safety plan is basically a version of a crisis plan. So clinicians in the audience probably would recognize that. You could come up with a crisis plan to address the cutting too, because most of the time what you'll find is cutters and people who have NSSI are escalating when they're in crisis. So if you come up with a plan to actually address the non-suicidal self-injury by helping the person be better at identifying crises early and coming up with a coping plan for what to do whenever their crisis is escalating, you could actually use a crisis plan to help with mitigating the non-suicidal self-injury as well.
All right, thank you. So this is a question about how implementing quality control for screening. Someone was interested in how do you measure whether the screening questions are even asked, and how to get the staff to understand the value of asking?
That's a great question. Oh my goodness, I've spent much of the last 10 years trying to answer that question. So I think it starts with the training, and I can tell you what usually happens here at UMass, which I suspect is what happens elsewhere too. I've worked in 4 different health systems, and it's the same everywhere. When you're trying to train active clinicians on doing something different, what typically happens is they slap it into a virtual training platform. It's e-learning for you here at UMass, and they push it out and they say, here, take this training. And then the system checks that off the list and says, okay, everyone's been trained. And if you've ever been part of a training like that, you know that it's just insufficient. Everyone just scrolls through that stuff. No one really pays attention to it. They do it to jump through a hoop. And maybe they've retained 10% of the content in those trainings. So that can be a starting point because it's something that's necessary and it's part of the culture of healthcare that this is how you do trainings. But you really have to do more than that with screening, even simple screenings. Our 3-item screener, it takes practice to use it, and it takes a face-to-face discussion with the clinician who's supposed to be doing the screening to describe the key points of what they need to do. Now, you can do that in probably 10 minutes. So it doesn't have to take a lot of time, but the key points, for example, you can't answer the question yes or no unless you have asked the questions or you have direct evidence of the person of the answer. So a person who comes in with a known suicide attempt, you don't have to ask the patient. You can say, yes, they had a suicide attempt because EMS and the patient's clinical condition is obvious they've had a suicide attempt. But you can't say no to that question that the person hasn't unless they're not presenting with a suicide attempt or that you haven't asked them the question. So they'll routinely answer these questions without actually having asked the patient. So some of the key points that you have to do a good screening has to be done face-to-face with someone who the clinician is either identified as a trainer or is accountable to. So that has to happen. And the way we track whether or not it's being done is through several different modalities, some of which are easier than others. One modality is to have the managers of the people who are doing this simply checking in with them and asking them or observing them. In some healthcare systems, this observation by trainers or resource personnel or managers is expected. And they'll do it for other procedures too, not just suicide risk screening. So observation of the clinician by someone else is one strategy. That's hard, but in some places it's already part of the workflow. Even if they can't observe them, then I think there's probably some value to the management at least asking the questions about whether the person is actually doing the screening and asking all the questions. The other way to do this, which is the way we've actually done it for our research studies, but is probably not practical for clinical settings, is we go after the patient has been seen and we ask the patient within a pretty short period of time of the documentation whether they were asked those questions. We do that for research purposes because it's important for us to quantify this for our research studies. But it's probably not realistic to do in a clinical setting. So it kind of depends upon whether you're trying to study this or whether you're just trying to implement it. There are differences. What's really fascinating, even within our own health system, there are dramatic differences between emergency departments. For example, with some emergency departments, we'll get a consistent 85 to 90% of patients say, yes, I was asked that question, versus the lowest is 40 to 45%. So that's not by accident. There's definitely something there. There's something going on there. And the ones that are the best performers have very active nurse managers and nurse educators. And when we rolled this out, they were talking with their nurses. They were asking questions. They did it repeatedly, not just once. They had they used their nurse huddles to reinforce the message, and it was clearly communicated to them that this was a priority, that it was important. It wasn't just a hoop to jump through. And during those discussions, they asked questions of the nurses. Well, what do you find challenging about this? So that they got their feedback during those discussions so that the nurses could share their observations. And actually, as a result of that, they brought that back to the team, and we modified some of our protocols and some of our job aids because there were things that weren't clear. So it was that engagement between the nurse managers and the nurses that really increased the fidelity to the screening.
Wow, all right. So I have one last question, and then we're going to have to wrap up. So in either of your past studies or your current studies, have you tested this approach with children and adolescents, or has it only been adults over 18?
So our system of safety, which is our zero suicide model here, our screening starts at age 12. So universal screening is at age 12. Any child who's presenting with a psychiatric presenting complaint gets screened if they're younger than 12. So if you look at epidemiological trends in age, you start to see an increase in suicide attempts and suicide at around 12, and it really starts to spike around 14 to 16 years old. So we use 12 as our threshold because it's very, very rare to have suicide attempts or suicide in individuals younger than 12, but we recognize that it does happen. So that's why we emphasize that if the person is presenting with any kind of psychiatric or behavioral complaint, that they should be screened. And so all of our protocols that I described, everything that I just discussed today, we use with individuals 12 and older.
Wow, okay, that's awesome. Well, not awesome in the sense that they present that way, but that you go that young. Well, I just want to thank you, Dr. Boudreaux, for your hour of time and this wonderful presentation. I hope that everyone has a lovely day. This will be available on our website, and please keep a lookout for future webinars. You can sign up for our listserv, where you'll learn about new products that we've developed or upcoming webinars. And I hope everyone has a lovely day. Thank you very much.
Thank you. It was a pleasure. Bye.
Bye.